happy to have all of you join us today for the webinar with Claudia Kraut. I'm happy to introduce her. She's the principal of Health GMT, and she has 30 years of experience in commercializing in the US. Claudia, you can begin.
Great, thank you. Great to meet you all. Welcome. As Mia said, I'm Claudia Kraut, and I run a company called Health GTM, Health Go-to-Market. So it's an advisory that helps growing health tech firms with their go-to-market plans. I work mainly with post-revenue companies that have a product in market and they're looking to expand into new markets, new customer groups, new channels. Sometimes I work with startups and early stage companies, sometimes with entities that are about to go public, but always a company that is at a growth stage and at the intersection of tech and health. So to give you a sense of what some of my background is, as Mia said, I have 30 years in the healthcare world. I've worked at various health plans, digital health companies. And so I currently, work with companies on designing their product market fit, their distribution partnerships, sometimes designing what their sales team structure is going to be, their hiring plans, and often working with their investors. To give you a sense of geographically, my background, I was born and raised in Stamford, Connecticut, and spent most of my vacations actually in Israel. I attended high school on a kibbutz, Kfar Blum, up in the Galilee. I finished high school in Massachusetts, went to college in New York, moved to Tel Aviv to get my MBA, moved back to the US in Miami, Florida, had work in Wichita, Kansas, Minneapolis, Minnesota, moved back to New York. I spent 2 years living in Singapore, moved back to New York, and much to my shock and surprise, I ended up back in Stamford, Connecticut, which is where I raised my 3 children, one of whom is currently living in Jerusalem, serving in the IDF. This is an old picture, that must have grown up than this. And other passions include rock climbing. That middle child is an instructor in rock and ice climbing, and trail running. So that's kind of me as a person. Our objective today, ideally by the end of our time together, you will have some good concept of commercializing in the US healthcare market, whether you're selling into health systems, provider practices, employers, consumers, whatever your target is. You obviously need to sort of follow the money, right? Without reimbursement, the path to sales is incredibly difficult. So hopefully we're going to go through during this hour the most significant payer entities, how they operate, what their objectives are, and how you can create a plan for commercialization. So the basic types of healthcare payers, we have government-funded models, commercial models, and then there's sort of an other basket that we'll go through. The Medicare market, which covers about 63 million people, is for the elderly and retirees, people 65 and older, and certain disabled individuals with things like end-stage renal disease. Medicaid, and we will go into each of these, by the way, in much greater detail. The Medicaid program is a joint program between the states and the federal government. It's currently covering about 82 million people, and it's primarily designed for low-income families, children, and some working poor. The healthcare services that are funded by the federal government that service our military and our military veterans are TRICARE and the VA. TRICARE covers about 9.5 million people. This is healthcare coverage only. There is a combination of owned military facilities, owned healthcare facilities, and provider networks. You are probably very familiar, but I'll just say in the US, we don't tend to own our healthcare delivery system. Those tend to be independent providers that are contracted with health plans, although there are some variations. With everything I say, there's always variations on it. The VA, the Veterans Administration, offers a number of different services. It has disability and pension. It also has healthcare. So the VA also serves in healthcare. Most Americans who are working receive their insurance through their employers. There are 2 basic ways that the health insurance world works for employers. One is fully insured, where there is a health plan that takes on all of the financial risk and does all of the administration and all of the government compliance, all of the network development. And so the employer pays a set premium that the health plan determines based on usually community risk at this point, if it's a smaller company. And so the employer has a set fee, there's some certainty of expenditure, and on the other hand, it's at the mercy of the health plan, whatever that premium is going to be, but the health plan assumes the risk. The other basic model, and again, there are nuances to this and we'll go into it, is self-insured, where the company actually, the employer takes on the risk of what that health cost is going to be. And it's called self-insured or self-funded. And so they will hire someone else to do the administration of it typically, but they will actually fund the pool of dollars that covers the cost of care. And then there are many who buy their coverage individually, not through their employers. They either go directly to health plans or onto the exchange, which is the Obama era Accountable Care Act. And there's a marketplace where the plans are dictated. There are, 4 tiers of plan, and so it's very easy to compare. So an individual who doesn't have a lot of health insurance experience can go on and figure out what they need to buy. The other bucket is sort of other payers. TPAs, or third-party administrators, are the entities that typically, in the event of a self-insured employer, right, that employer is going to fund the healthcare cost risk, but they are not necessarily going to determine what all of the benefits are that they're going to cover. The TPA will help with that. They're not going to create a provider network where their insureds can go to the doctor. So the TPA will handle that. The TPA will do claims administration, it will do claims adjudication, it will do member services, etc. There are some times when the health plan, the insured coverage, and the provider network are integrated. Sometimes there are health insurance companies that acquire provider practices or hire doctors, sometimes even own hospitals. Sometimes it's a hospital and a hospital system that decided to open an insurance carrier. So occasionally it is integrated. And then there are PBMs, which are pharmacy benefit managers. They have responsibility for creating the kind of tiered lists of what types of drugs are covered and at what level, and then administering and adjudicating the pharmacy benefit. In any of these, the objectives of these payers, whether it's the employer or whether it's the health plan, obviously they want to maintain, total risk, the cost of care. They want to manage risk in terms of their financial risk, the risk of malpractice, etc. Quality improvement, they are theoretically always trying to make themselves better. There's lots of room for improvement in the US healthcare system. Member satisfaction, lots and lots of regulation. In the US, many of these plans are regulated by the state Department of Insurance. Some of them are regulated by the feds. Some of them have to answer to both. And then, of course, there's bottom line, profitability that they worry about. So to dive a little more deeply into the Medicare piece, Medicare, as I said, there are about 63 million people on Medicare, mostly seniors, some who are disabled. The Medicare program has been funded throughout the course of one's career through payroll deductions. There's also part of the federal operating budget that goes to it. And as an individual goes onto Medicare, they actually pay a premium for that care. Medicare has Part A, which is all of the inpatient care. Sorry, didn't mean to do that. Of the inpatient care, skilled nursing facilities, some of the home health care. There is a deductible per year. Medicare Part B is the outpatient care. That's where the premiums come in. So Part A, you're covered for. You've paid into it your whole career, and you receive this coverage with a deductible, but then usually a co-insurance of some sort, but you're not paying premiums. Part B, the outpatient medical, if you want this, you have outpatient care, some preventive care, doctor's visits, durable medical equipment, mental health services. So there is a monthly premium, there is an annual deductible, and there is a co-insurance. I'm going to back up for one quick second, realizing you might not be living in this terminology. So the premium is the monthly bill that you pay to the insurer to cover their services, including your medical care and including all of the kind of administrative services that go around it. The deductible is the amount of money that you have to pay per benefit period, usually per year, before any insurance kicks in whatsoever. So in this case, of Medicare Part B, this year, a Medicare beneficiary was required to pay $257 out of pocket before the Medicare even started to pay the insurance claims, and co-insurance 20%, so 20% of the cost of any given bill, as opposed to a copay, which is going to be a set amount of money, usually $25 or $40 or $100. That's a copay, flat amount. So in case that wasn't obvious. I'm going to skip over to Medicare Part D. It's newer. It came about in about 2003, but Medicare finally started to pay for some prescription drugs. And Medicare Part C is actually, it's Medicare Advantage. It is a private-public collaboration. So the federal government determined that it was costing them too much money to cover Medicare beneficiaries. And they decided that they would lay off some of that cost. They would allow private insurers to come in and offer it more efficiently. So what the federal government does is pays a capitated rate, so a per head rate, to a commercial insurance plan, and says, based on this risk stratification, this type of patient of this age with these health, with these kind of chronic conditions, et cetera, is going to cost us X amount per year. We're going to give that to you. And we're going to assume that you are going to manage that more efficiently than we would, which means you must offer at least the same benefits that we do. And since we think you're going to do it more efficiently, we're going to limit your profit on this. We're going to say you also have to offer additional benefits like dental care, like hearing aids, like vision care, like wellness programs, all kinds of sort of extras. And so the beneficiary doesn't pay extra for that. They can choose it, and then the feds will pay that private insurance company. Also, there's a cap on what that person's out-of-pocket cost is going to be. So, for example, in 2025, if you went in the prescribed network of your local Medicare Advantage plan that you had signed up for, you're not going to pay more than $8,800 for your care in that year. There's another addition. If you don't want to sign up for the Medicare Advantage private plan, you want to stay on the government administered version of Medicare, you can buy something called Medigap or Medicare Supplement. You pay a premium for it, but it covers things like your Medicare Part B premium. It'll cover parts of your co-insurance. It'll cover parts of your deductibles, but it doesn't cover some of the other things that Medicare Advantage will pay. So again, nothing simple in the US healthcare system, but that's Medicare for seniors. Medicaid is a state and federal partnership. The feds fund part of it, half to 3/4 of the cost of the care, but the state administers the program. It's typically for low-income families, some seniors, some people who are disabled, and during COVID, it was expanded to low-income working adults as well. And there are about, as I say, there are about 96 million people on this program. There is a list of required coverages that the feds require that each state covers: inpatient and outpatient services delivered in a hospital, outpatient physician services, certain diagnostic care, and nursing facilities, home health services, and diagnostic and preventive care for children. Some Medicaid plans use fee-for-service payments, meaning whatever the doctor bills or whatever the hospital bills, they will reimburse for that care. Typically, they will contract with a network for a discounted rate. So the provider will bill, but Medicaid will pay less. But nonetheless, some of it is still on a fee-for-service basis. More and more, there is managed Medicaid. The way there was Medicare Advantage, they're doing the same thing, kind of farming it out, laying off that risk to a private insurance company. And then, of course, they're contracting with managed care organizations and accountable care organizations to, so an accountable care organization will be a conglomeration of inpatient, outpatient, physicians, hospitals, and they will take on the risk of a patient's full package of care for a certain rate. So they're using both types of payments. I'm a little bit less familiar with all of the government things. I sort of spent my career living in the employer world, but TRICARE is really the healthcare program for the active duty and retired veterans. The government owns some of the treatment facilities, but they also contract with civilian networks of providers and hospitals. There are different levels of coverage that you can have, and the costs are going to vary based on which plan you pick and whether you are active duty, retiree, the family of a veteran, etc. The VA, the Veterans Administration, as I said, offers many, many types of services to veterans, but in the healthcare realm, this is funded. Congress appropriates a certain amount of money for the year for this care. The VA does use its owned networks of providers, hospitals, clinics, outpatient providers, etc. It is for veterans and not for active duty military. Anything that is a healthcare issue that is related to your service is covered in full. The rest of it works a little bit more like a commercial health plan. And Medal of Honor recipients, etc. Certain people receive slightly higher levels of eligibility. I don't think they receive different levels of coverage. In the employer world, and as I say, this is where I spent sort of most of my career. Most of the people in the United States, receive their coverage through their employers. We talked earlier about there's fully insured and self-insured, but there are flavors. So we'll get into that a little bit more. If you are looking to sell to patients through their employers or to patients, and you need to understand what their coverage is, most of them are going to get it through their employer. Smaller businesses tend to be fully insured. They just don't have the budget to take on the risk of paying their own claims. So as I said, they'll pay a fixed premium. You have cost certainty. You're paying a fixed premium to your health plan, and everything is, everything is taken care of. Of course, there are double-digit increases year over year in that premium. So it's not a particularly great deal for them, but this is kind of the easiest way to go through it. And as I said, there are different ways that the payers will pay. So fee for service is, they'll pay based on the billed charges for a particular visit, for a particular hospital stay. Sometimes they will do fee for service. Sometimes they will contract with a provider group, usually an integrated provider group where there's inpatient and outpatient, and they all sort of work together, and they'll do something in episodes of care or value-based reimbursement, or there'll be shared risk between the payer and the provider. The standard types of plans that you might get in a fully insured or a self-insured, the way that the kind of access to care is structured in the employer world, an HMO is one of the more restrictive. Basically, what they're trying to say is the smaller we make the network of providers that you can access, the more control we have over what we pay those providers. Because if I create a network of providers and I say I have 3 million members, and I'm going to send all of those members only to you, this small group of physicians, then we can pay you less because we're sending you so much volume. From the user's standpoint, the more freedom you have to go wherever you want for care, the more expensive it is for you. So HMOs tend to be among the less expensive. It's a health maintenance organization. Typically, you will have to receive approval to go to a specialist. You have to kind of get everything through your primary care doc. It has changed over time. It's a little bit less rigid now, but nonetheless, this was the originating principle. You have to get everything through your primary care. You have someone who is actually directing your care. So you come in for everything through your primary care doc. They will refer you to a specialist, and then that care will be covered. It will also be reviewed by the health plan, but it will be covered. Sometimes an HMO will actually hire its own doctors. So that's one of those integrated models. An exclusive provider organization is kind of the most limited. It's a very small network, a narrow network program, it's sometimes called. And so again, because we are restricting where you go for care, we are able to channel more business to those providers, therefore pay them less because we're sending them volume. We also have more of a dialogue with them. We can sort of, we, the carrier, can get a little more involved in what types of care are being delivered and whether you're going for the right level of care at the right time. A PPO is a preferred provider organization. So you have, we'd like you to go here, but if you don't want to go to these providers, you can go to those providers. You're going to pay more. And then high deductible health plans, which are a bit more recent, where, you know, the deductible overall, instead of being a couple $100, is going to be 1,000, 5,000. It can be more. There are varieties, but the idea being you will pay less in your monthly premium in order, but you will be paying more as you actually seek care. Self-insured plans, as I said, the employer is actually assuming the risk for the claims, and they'll usually hire either a health plan or a TPA to do the administration, to do the claims adjudication, to do the member services, to do the, you know, the regulatory compliance, all of that. When the employer pays for their own risk, they therefore have a little more control and say over what benefits are actually covered. So they have more of a voice in designing what the health plan actually looks like, what the coverage actually looks like. And also, of course, they set aside a certain amount of money for cost of care. If the care doesn't hit that amount, they get to keep the excess versus giving it over to the health plan. So you have a lot more savings. Sometimes an employer will actually set up its own insurance company, and that's called a captive. It's my own insurance company that deals just with my employees. So I'm not using it for any other population but my own. And some mid-sized companies that cannot afford to either self-insure or set up their own captive will join forces, and there will be captives of, you know, a limited number of mid-sized employers that will pool their risk. So they're not pooling it across a health plan and an entire country or whatever that service area is. It's just, you know, the 10 of us, the 20 of us, the 50 of us. And so that offers, again, more customization in what the benefits look like, more control over how it's being administered. And of course, if they come in under budget, they get to keep some of that money. And yet another variation on the theme is what's called level funded. It's really a hybrid. So the employer is going to pay a fixed monthly premium, and that's going to cover the claims fund. It's going to cover some of the admin, and they're going to buy a stop loss policy. Same with the captive and insured. They're going to buy a stop loss policy for any claim over usually about $1 million. There's another insurance policy that comes in and covers it. But the level funded plan allows the employer to have a set, you know, cost certainty, set monthly premium. However, they've pooled that money. So if in fact the claims come in under budget, they get to share in that savings. So this is, if you have a healthy workforce, that's really good. If you're too small for either captive or self-insured, level funded can also be a really good way for them to go and save some money. You have to have a bit of a long-term mindset for that type of thing. Hospital health plans, again, we said, you know, sometimes there's going to be a combination of the health system and the health plan are combined. So sometimes it typically started out that the health systems wanted to just insure their own people. Then they realized they could insure their communities. And so now you have health systems that have established health plans, insurance companies, because they figure they are owning the inpatient, the outpatient. They've got the ability to manage a patient's care across the lifetime of that patient and throughout their community. And so they will offer all types, you know, they'll offer to all of the different communities, and they're sort of aligned, you know, their interests are aligned as opposed to a more adversarial relationship. And admittedly, there is a really adversarial relationship in the US between the health plans and the providers. So, you know, this allows them to really kind of be clinically integrated. So we are both managing our risk and managing the care. So we kind of have those interests aligned. We want that patient to do better while we are optimizing our revenue. Just sort of gets that aligned. We have the ability, because we have the insights and the medical records of these patients, we have the ability to, you know, do risk stratification and understand where we want to invest our resources and how we want to do, our healthcare across this population. Where do we want to sort of focus? The value-based contracts, if I am the insurer, I obviously want to optimize the value and the care outcomes for each of my patients, and anything that's a cost savings, rather than letting the insurance company keep all of the profit, I'm able to keep it and I'm able to invest it back into my actual healthcare infrastructure. So it's a really nice way to go. Just for case you hadn't heard of them, I'm giving you kind of 5 of the biggest. So Kaiser Permanente, which is out in California. Interestingly, UPMC, Geisinger, and Jefferson Health are all in Pennsylvania. Not sure why Pennsylvania is so big on the integration program, and Intermountain is in Utah. And just as an example, so Geisinger, which is, as I said, in Pennsylvania, has about 3 million members, and it offers individual plans on an ACA. It offers Medicare Advantage. It offers Medicaid. It offers a children's only plan. It offers group health plans to employers. It covers people who are eligible for both Medicare and Medicaid, and it offers a high deductible health plan. So they can be very, very flexible in what they offer. If you are selling into health systems, some of their key pain points, which is obviously critical to know, you have to understand what problem you're solving for them. Major staffing shortages in this country in healthcare. So if you can reduce the time that it takes to deliver care, if you can, be kind of a force multiplier to allow a better distribution of their limited staff over the patient base, if you can make care more accurate, more efficient, if you can lower the cost for them, patient satisfaction. People are not very happy with health systems or health insurance in America. So anything you can do to improve outcomes, improve satisfaction is helpful. And of course, anything to help them with the absolutely onerous burden of regulatory compliance is all really helpful. The various folks you might be selling to in a health system, of course, are the doctors, nurses, etc., who are actually going to be using the product and can be some of your greatest champions in selling it upward into the administration. The department heads who are looking at it more, less from the standpoint of what am I going to do every day, but rather how is my department going to be functioning with the use of your technology. There are often large committees that you have to go through who are going to look at every aspect of your product, how it works, whether it's efficient, whether it's, cost efficient, whether it's safe, what it, kind of how much it's going to integrate into our workflows. Obviously, total cost of your product versus the cost versus whatever the value of your product is going to be important to the administration of the hospital. And how easy is it to integrate? More and more and more, the solution that is easier to integrate into their workflows, that causes the least disruption, even if you would think that it's a fabulous solution that's changing medicine, if it's too hard for them to integrate into their existing workflows, is going to have a lot of headwinds. So generally speaking, as you're selling into these health systems, if you have something that is being used clinically, whether it's record keeping or surgical devices, robotics, anything like that, if you can get those clinical folks to adopt it, to love it, to be enthusiastic, to be your champions within the organization, that's going to be a great starting point for selling into these systems. And then make sure that the value proposition for those clinicians is actually aligned all the way through the organization, right? The value proposition has to speak to the end user, but it also has to speak to patient outcomes. It also has to speak to workflow efficiency. It also has to speak to cost effectiveness. So make sure that all of that is kind of clearly established. And as much as you can do in modeling out the finances or showing them use cases, the better to make that case. We used to talk about pilot programs. Pilot programs are not great for you because it's free to them, and then you might never get there. So, but at least a partial rollout, right? Sometimes you can't get the full rollout. I wouldn't really offer things for free if you don't have to, but to allow them to test it in a low risk setting, a limited thing, a limited time period, a limited patient base, some good, strict kind of metrics around what success is going to look like will often get you that foot in the door. And then, of course, anything you can do on the implementation end to really support them using it and support the adoption so you can land and expand. Just sort of generally, and you're probably well aware of these, but wanted to just mention some of the things in the health system world that are particularly gaining ground. Anything that uses AI that will make things faster and more efficient for the providers, particularly, the sort of note taking, putting something into the patient record, that's really taking hold. We're hearing a lot about that. Diagnostics, of course, communicating with the patient so that it's not actually taking the clinician's time. That's really becoming popular. Anything virtual first, whether it's integrated into the hospital's own provider systems and the hospital's own EMR and the hospital's own workflows, or whether it's a standalone external solution that can nonetheless provide relief for the hospital providers, like an Omada, which deals specifically with metabolic, or Oshi, which deals specifically with digestive issues. Any kind of virtual first, getting them in that front door digitally is really gaining ground. And then again, anything that's going to reduce clinician burnout and improve quality. So, again, the kind of just anything that alleviates their internal systems, their internal workflows, that can take on some of the burden of what they are doing behind the scenes that is not directly patient care related, is gaining a lot of ground these days. I must have been speaking very, very quickly because I'm about 8 minutes ahead of schedule, but to kind of just look back and summarize, as you are looking to commercialize in the US market, follow the money, right? What is your customer? What is your customer's payment pathway? Is your customer the health system that owns its own health plan? Is it the health plan itself? Is it working against a health plan because it's the health system that is trying to get reimbursement? What patient populations are they tending to deal with, or what other method of payment are they receiving? And understand the value proposition of your solution in the context of how they are receiving their revenues. Are you reducing cost for them? Are you helping them with customer retention? Are you improving clinical outcomes? Are you reducing time? And how easy is it to integrate with their existing workflows? The less friction on implementation, the better off you are. As for yourself, what is your funding structure going to be? What is your payment pathway? Are you going to contract directly with an employer, with a payer, with a health system? Which of these, understand where they're getting their funding, and then understand how you're getting yours, and do your objectives align with theirs? Is what you're offering going to help them with their problems? Do you need to have reimbursement codes, right? Are you going to need approval? Are you going to need, are you going to need to make sure that you've got a billing code because you're billing through the health plan system, or are you not? Are you able to share in savings? More and more, the fee-for-service world is sort of taking a back seat. There used to be, bill fee-for-service. There was a per employee per month or per member per month, kind of a capitated fee. There's a lot more momentum now around sharing in savings, or billing based on engagement and utilization. So it's not just that it's out there for the population, but we're only billing for the population that uses it, or we're only billing from the population that we can prove benefits from it. Depends on what your product is and what it does. But the more you can do kind of a shared savings or an outcomes, the better that is. And there are often, grants out there. The state programs, the federal programs, the veterans programs will frequently offer grants for new products or for studies. So you'd want to try to take advantage of those. Kind of mentioned, if you need the coding, but also if you need FDA clearance, if it's a device, are you HIPAA compliant? Do you have SOC 2? Are you high trust cleared. You need to make sure that you have all of the data security that this system is looking for. Do you need to have peer-reviewed studies? Do you need to have, case studies? What other kind of real-world evidence can you bring to make your case as you go to sell? And obviously building relationships with the team that you're selling to, but there are other organizations out there that can really help you. There are a lot of digital health accelerators in the US. There are innovation teams. Some of them are run by benefits consultants. Some of them are run by the health systems themselves. Some of them are run by nonprofits that are looking to improve care across the spectrum. So what other organizations are out there that can get you to your market in an effective way? And then, of course, the providers that are going to benefit. Who can you partner with that you might not be selling to, but strategically you can create partnerships. And this is what I do a lot for a lot of my clients who are looking to go to market, and we find them partners that can speak on their behalf, that can integrate with them, that can make it a part of their portfolio, so that the founder doesn't have to do all of the sort of direct selling. So there are many, many options out there in the market to open those kind of doors. And with that, that's it. Happy to take any questions. This is how you can reach me. And as I kind of mentioned to Ariel at the beginning of the hour, I'll also be in Israel in December. So if anybody wants to meet, happy to grab a cup of coffee and talk about your specific product and your specific offering, and what we might be able to kind of think of to help you accelerate your commercialization.
Thank you, Claudia. It was great. It was really interesting. I see a question in the chat from Ran. He asked, what out-of-pocket costs are paid under Medicare Advantage? Is it a 20% co-insurance?
So I hope I answered that a little bit as I went on. So co-insurance, again, if you're being billed on a fee-for-service basis, so you are paying. Oh, hi, Mary. Thank you. I just saw that check come up. If the provider, the physician, the hospital is billing based on the service they provided, so you have a $10,000 hospital bill, or you have a $300 doctor's bill, 20% co-insurance means you're going to pay 20% of that bill, versus a copay where you might have $100 a day for inpatient, or you might have $25 for a doctor's visit. So the co-payment is a set dollar amount, and the co-insurance is the percentage of the total allowable bill. When I say total allowable bill, it's because, again, the provider might bill you $500, and Medicare might say, we only recognize that as a $300 service. So then you only owe 20% of the 300 versus 20% of the 500.
I hope Ran is
That's
still with
helpful.
us and could hear I hope it answered your question, Ran.
Yeah, I'm here. Thank you.
Does anyone else have a question for Claudia?
Yes, I would love to ask, or do I need to write it down on the chat?
No, it's fine. I hear you.
Okay, I would love to ask if you have any specific tips for companies who their markets are specifically in ICU, any specific reimbursement tips, because the payment system is usually based on the different DRGs and specific CPTs, and not so expanded as the ones that you explained about in this webinar.
So tell me, sorry, everybody, tell me a little bit about the product. Where does it fit into the ICU care that's being delivered?
So the product is a urine output monitoring system, which is supposed to give a better hemodynamic picture on the patient's status and on his volemic status. So it's basically could be a predictive tool for AKI and for better fluid balance.
Okay. So if you are working in, in an ICU and you're working in the DRG world, the provider, that health system is only receiving a certain amount of payment for that patient based on its diagnoses. So if your analysis can identify additional illnesses, additional diagnoses, additional codes that they could bill for, then you are optimizing their revenue under their billing modality. And so the way to sort of position that, I would say, to the providers delivering the care is that this is going to give them much greater insights into the patient's condition and allow them to kind of understand what's going on and be able to provide the appropriate type of care for something that they might not otherwise have seen. And then when you're going to the department head and the administrators who are looking at total profitability, they don't want to add an expensive service to something where there's a limited revenue potential. So what you're going to say to them is, well, here are a dozen cases where we identified additional conditions that the provider individually would not have identified, and you are able then to expand your billing based on these additional diagnoses. And so we're actually optimizing your revenue. So to the clinician, we're helping you deliver better care, and to the hospital, we're helping you optimize your revenue.
Thank you. That sounds really interesting.
Excellent. Anybody
Okay.
else?
I can ask a question. if anyone
Alex.
is in the line.
Alex asked me, it's healthgtm.net is my URL. And I will warn you, it's a terrible website. I've never bothered to do much with it because I just do the work that I do, and I kind of have never. So if anybody knows somebody who can build an easy website, like, it's not what I spend my time on. I spend my time on this stuff, but it is healthgtm.net.
Mia, should I ask a question or there's questions in the queue?
No, you can ask.
Hi, my name is Gal. I'm one of the founders of MCI. My question to you is, since COVID, the face-to-face interaction with payers is more restricted. So how would you suggest companies would approach payers and interact with them in order to engage them?
Interesting. I think that's opening up quite a lot. I do a lot of work with the payers and also with the benefits consultants who advise the employers as they're buying their coverage. And from 2020 to 2024, there were virtually no on-site meetings happening with those consultants. And now they're happening again. They're coming in, they're doing lunch and learns, people are visiting. I actually work very closely with Cigna for one of my clients, and we've had several on-site meetings. So I think that's opening up a bit, but in general, it is really hard to get into the payers. It really, really is. And the somewhat discouraging answer to your question is it helps to know someone, right? You can sometimes get in there by having a fantastic idea and a fantastic product and a fantastic sales deck. Like, sometimes you can. It does help to figure out who's the innovation team that is working with the piece of the system that you are looking for. So if you're, if you want to work with a carrier, whatever it is, if you, on mental health, and if you can find the mental health innovation team of that carrier, sometimes you can sort of get in there. So it's a bit of legwork to find the right people. You do have to target things pretty carefully. And then honestly, it certainly helps to have somebody with personal relationships who knows that carrier, who can at least get you in the first couple of doors. And from then on, it is really it's yours that carries you. If you want to get to a carrier and can get first to an employer, the employers are kind of the primary customers of those carriers, and they carry a lot of weight. And the employers do not want, even if the employer is self-insured, but is contracting with the health plan as their TPA, right? They're contracting with them for the provider network that they're going to use. They're contracting for the member services. They're contracting for the claims adjudication. The health plan does not want to lose that client. So if you can interest an employer in your solution and say, can you get me into your carrier? That is often a good way to go. Secondarily, to go to a health system and say, can you get me to the carrier? But that's, as I said, sometimes a bit of a contentious relationship. But if you can get to an employer or a benefit consultant or the innovation team in that area of the health plan, that's usually a good way to go. And yes, nepotism, protectia is like the best way.
Thank you.
Oh,
Hey, can I ask one more question, or is it already time out? Running out
I
of
have a
time.
minute.
So if that's okay, I have just a quick question. So we developed basically a screening tool, and when we build a business model, we show like the hard value of the business tool, like how we can, for example, save referrals to specialists, and the soft value that by catching the disease early, we can reduce further comorbidities. Now, then I was wondering, you talked about the time saving and the patient, customer experience. Is it any way to quantify it, like add it as a value, or is it something that you just usually highlight as a fact, like that we improve the patient experience?
Yeah, that's a great question. I think the time value can be quantified, right? Because you can compare your solution to a traditional method, and you can look at, if you have something that can be sent home with the patient versus a nurse administering or having to go to another clinician, right? You can kind of quantify that pretty objectively. The patient satisfaction, if you can take surveys, it doesn't hurt. It is more of a soft value. The time saved is a hard value. I would consider that to be a key point for you. The money saved and the time saved and the resources saved are very significant to payers overall. They like to hear that you're giving better care, and they like to hear that patients are satisfied. Absolutely. And adoption rate, if this is something that you have to say, like, patients are using this, and this is the pace at which patients are using it, that's very helpful. If it's something that the clinicians need to adopt and be giving to their patients, if you can have data around clinician adoption, even if in the early days it's just survey data on how much the provider is open to it, how much they are using it, we only deployed it among 10 providers, but they're now using it for 50% of the patients that they would have used this time-consuming process in the past. That is valuable.
Right.
That's absolutely valuable.
Thank you very much, and thank you for the webinar.
You're welcome. Absolutely. I'm going to put something in here. healthgtm. There, somebody asked for my email address. There it is.
yes. Okay, good. Thank you so much, Claudia. It was a perfect webinar. We will be uploading it to our website by the end of the week for anyone wanting to see the recording. And thank you all. Have a great rest of the week.
Thank you all so much. Great to meet you.
Thank you.
Thank you.
Thanks a lot.
Thank you, everybody.
Thank you.